All right, to continue, there are some unusual genetic anomalies that can happen with the ribs. Sometimes you have ribs that attach at C7, and occasionally you get 10% of the time this can cause thoracic outlet syndrome, which is it causes nerve or vascular impingement at the thoracic outlet up at the superior top of the bony thorax. And this is the thoracic outlet. There is the space between the base of the neck and the armpit. So not very often do you see cervical ribs, and only occasionally from there does it cause this thoracic outlet syndrome. And there is a bifid rib, which is on this image, and I'm not going to tell you where it is, but I want to see if you can find it. I'm going to ask you about it on the quiz. Where is the bifid rib? Which rib has it? And usually it's unilateral, and it's fairly uncommon, but sometimes you'll see it, and it looks kind of like this. That's why I put that on there. Sternum. So the sternum, you're probably, if you ever see it, you maybe only see it once or twice in your career, but they're very difficult to get and get them right. So when you're positioning for the sternum, it's usually two views, the PA oblique, RAO position, and it's the RAO because it uses the shadow of the heart to help with visualizing the sternum a little bit better. You don't want to be too far obliqued because you're trying to keep the sternum relatively flat. So it's a very shallow oblique, 15 to 20 degrees, and the patient can be laying down or standing up, either way. It's very shallow oblique. So it's a good idea to, when you're positioning for these, to have the patient facing anteriorly so you can see where their sternum is, and open your collimation so you're about an inch to an inch and a half, an inch and a half above the top of the jugular notch and below the xiphoid. So you're going to center along the long axis of the sternum. If you get your collimation open properly, then when you turn the patient around, it'll be a lot easier and just to line the sternum up with the midline of the image receptor. Because it's hard to tell in the back if you're in exactly the right place, and the light field may look too small. And so you typically, it tells you right here where to center if you're centering from the posterior, but I would say have them start facing you so you can see the part and get your collimation just about right. Once you get it right and get them lined up against the image receptor, you bring your distance in to 30 inches. So just be sure you're at 30 inches before you line up the collimation, because you want your light field to be the right size. So as far as lining up on the posterior, you want to be 1 inch lateral to the mid-sagittal plane at about T7, where you center for your chest x-rays. All right, here is what the sternum looks like. Here's your anatomy, and this is what your patient will look like. So, I don't think I've ever seen one that looks this good. You can see the scalloped edges where the ribs attach along the sternum. Right along here. The xiphoid is pretty small right here. You can see right there, it's just very little. And the manubrium, and the clavicle, the notch. So these are the things you're going to name when you show me these views. One of the things that's really important is to have a breathing technique and that shorter distance. I don't know how the Jeff might do it at the site, or Jocelyn might do it at the site, but in the book, just so you know, it says 30-inch SID, and that helps to blur out the ribs a little bit with a shallow breathing technique. Blur out the ribs a little bit and magnify the sternum just a little bit. So this is at regular 40 inches with no breathing technique. And this one is a shorter SID and the shallow breathing technique. And you can see how much better you can see the sternum in with this technique. So think about it. It's you're not going to see them very often, but I would give it a try because this is what I typically see, if even that clearly, and it's very difficult to see the sternum in that view. So here's what you need to look for as far as evaluating your image. I'm not going to read this to you. You can read it, but you want to be able to see it like on that last image. And next, we're going to look at the lateral sternum. The lateral sternum is so much easier. The patient is upright or supine or on their side. You can do it any which way. You want to have 72 inches distance for this. That's going to help because of your OID that you have. The sternum, of course, being in the center of the chest, and it's far enough away from the image receptor that you're going to need some more distance to account for that. 1.5 inches collimation. You want the IR above the jugular notch, and that will help you center mid-body and get your collimation open where it needs to be. So you can do fairly tight collimation. You can see how you can do these lying down too. So you only need a 10 by 12 film because, like I told you, the sternum itself, the whole sternum is only about 6 inches long. So 10 by 12 should be plenty. And this is what your image will look like. Good collimation. You want to see all the way from the manubrium down to the xiphoid right there. That one's a little tight, so you don't want to get it too tight, but you want to be able to see good detail on there. So 72 inches for because of the OID, so you can get better detail. Okay, the next slides go along with ribs, and the slides are a little upsetting, and I apologize for that right now. I know maybe some of you are sensitive to this, but it's important that you see and be aware of what your responsibility is when it comes to abuse. All right, so child abuse is what we're talking about. This little baby, mom decided to smash her head with her foot. So that's unfortunate. And this little child has been clearly abused by the bruises you can see on her. 700,000 children a year are victims of maltreatment. It's just so disturbing, and I'm sorry, but you're going to see it out at the sites, and you need to be aware of what your responsibility is. Shaken baby syndrome. This is where the ribs come in. Ribs get fractured when whoever's abusing the child shakes the baby and they're gripping their ribs so tightly it fractures the ribs. This is a 2-month-old child. 2 months. It's just unfathomable to me. And sometimes on the extremities, you're going to see spiral fractures, or you're going to see clean breaks. And when a child that young injures itself, you may see a green stick fracture because the bones are made so much up of cartilage. They're not solid calcium yet. So for a clean break and a spiral fracture, that means that somebody twisted or bent the bone in half. So for the father to say that he heard a pop when he was changing the baby's diaper, somehow I don't know. This is only a 3-month-old baby here with clearly a spiral fracture of the femur. Over here on this child, you can see the anterior ribs had fractures that are healing as well. So 2 months old and now has a second set of fractures on the opposite ribs. I think that child needs to be put somewhere where they're going to be safe. Now, as a healthcare provider, you are mandated by law to report any suspected abuse. All the sites that you are at will have a policy in place for reporting abuse, and it's mandated by the federal government as well as state laws. So you can look at your policies in your sites and find out what it is your responsibility. If you don't know what it is and you suspect abuse, whether it's an elder or a child or a person with disabilities or just someone you have in an exam room who reports to you that they are being abused and that they need help, you need to get a supervisor, a radiologist. If it's in the nighttime hours, maybe an emergency department physician, someone who knows how to report the situation, because these people will know for sure what needs to be done. Okay, so sorry to end on that unhappy note, but it's a hard topic, but you need to know what your responsibilities are along those lines. And we've all seen it. Any of us who have been techs for any length of time, we've all seen it. And you just do the best you can to take care of your patients and be someone who's good to that person who's not having the best luck in their life. So anyway, here is a link to my favorite YouTube video. It's been around for a long time, so you've probably seen it, but it makes me laugh every time. So I want you guys to have a great spring break and try to relax and not think too much about school. Take some time for yourself. You need it to rejuvenate. So have a good week off.